Good evening. Today the video is for my postgraduates who have missed today class on the diuretic. Since whoever comes to nephro posting, they always have this doubt, sir, when to convert IV diuretic to oral or oral to IV, whether to give Lasix, furosemide or torsemide. This we will try to sort out, or the understanding will be made better by seeing a series of classical cases. In this case series, we'll start with case 1 today. There are 6 cases. Once you understand the case 1, the rest is 5 cases we will see in another video. So that is why I am starting the slide from 43. Common case scenarios related to the diuretic use. Day in and out, you will be having doubts with respect to the diuretic dose adjustment, and try to see the clinical scenario and apply what might be your decision. And for each option, you will see the explanation why that option is correct or why that option is not correct. Case 1. There is a 56-year-old male who is a known case of hypertension, type 2 diabetes, chronic kidney disease, CAD, ICMP with a low ejection fraction. He came to the casualty with the symptoms of worsening shortness of breath and approximately around 8 kg of weight gain. And he was found to have acute decompensated cardiac failure. On asking the history, he was on medication which include losartan, oral furosemide, which is a dose of 40 mg daily, twice daily, atorvastatin and insulin. If we go to the general examination, the BP is on the higher side, the patient is in tachycardia, and all the signs related to volume overload is there. On the lab side, there is no major abnormality related to electrolytes, but patient creatinine is 2.1, probably AKI. Yeah, patient might be a background diabetic kidney disease. Whatever it is, these are all the basic detail with respect to the patient's symptoms, examination, and the preliminary lab values. At this point of time, what will be your treatment option? How you are going to decongest the patient? The option we are having are prescribe an intravenous furosemide or as an infusion, prescribe metalazone, prescribe dapagliflozin, or go for an extracorporeal isolated ultrafiltrate removal using the dialysis machine. Or the final option is stop losartan. Do you think losartan is the reason for this deterioration? So you can think on this option. What will you do if you are having this patient in the casualty? Either this, or this. So we'll try to solve this case. What is the major issue in this patient is volume overload. So what is volume overload? It is nothing but the excessive body sodium and water with expansion of the extracellular fluid volume, which can occur in cardiac failure, liver failure, CKD, or in nephrotic syndrome. The common pathophysiology which led to the manifestation, even though the etiology might be different, but the end spectrum usually patient presents with all the signs of volume overload that you are aware of. Pulmonary congestion, ascites, pedal edema, shortness of breath, fluctuating BP, especially high BP. As we know, diuretics are the cornerstone of therapy for the volume overload. And in case 1, what is the problem? He is already on Lasix, furosemide 40 mg twice daily, but he is not responding, and he had a significant weight gain of up to 8 kg. Many times patient won't respond to oral furosemide because of the gut edema. And how to bypass this gut edema? Since the patient is having generalized anasarca, the absorption oral bioavailability might also have been reduced. So the next best step in this is switching from oral to IV. So best option could be to go for a IV furosemide. Either can be bolus or as infusion. The route have to be changed from oral to IV. There are few guidelines which says the oral Lasix or furosemide have to be given at a dose of 2 to 2.5 times than the oral dose. Only Lasix to be given or furosemide to be given? No, you can give an equivalent dose of torsemide also, that is ditor or bumetanide. In India, the use of bumetanide is not that common. The confusion is always between Lasix and ditor. That is furosemide or torsemide. You can go with either of that, but a equivalent dose. The equivalent dose, I hope you are aware. Otherwise, the initial part of this presentation was having that. I will try to upload if I have time. With respect to this furosemide, oral to IV, it have to be 2 to 2.5 times higher, or the equivalent torsemide dose have to be given. So what about the other option? Yes, metalazone can also be given. What is metalazone? It blocks the distal tubular sodium reabsorption. Since loop diuretic blocks the sodium potassium 2 chloride channel, all the sodium goes to the distal tubule. Once we block this distal tubule, there is an increase in diuretic response. But in this acute situation, this metalazone won't be of much help as of IV furosemide. So first step is to go for IV furosemide, then we will consider it afterwards if there is no response to IV furosemide. Dapagliflozin. Yes, dapagliflozin have been shown to have beneficial effect in congestive cardiac failure and in CKD also, but that is on the long run, not in the short acute deterioration. At this point of time, it is not going to have much benefit and it won't replace the IV loop diuretic. Isolated ultrafiltrate removal. What is the problem with this? One, patient have to establish a vascular access. Two, patient blood will be exposed to extraperitoneal circuit. Three, it is associated with lot of hemodynamic fluctuation. And this is last resort. Suppose the patient is not at all responding to anything, patient is about to go, condition is about to go into worsen the state, then you can consider isolated ultrafiltrate removal. So at this point of time, since patient didn't respond to oral only, you can consider IV rather than isolated ultrafiltrate removal because of its multiple adverse effects. Stopping losartan doesn't have any direct relation with volume overload. Yes, losartan can be stopped or have to be stopped if the patient is in AKI or if the patient is having hyperkalemia. At this point of time, there is no much relation between the patient volume overload and stopping losartan. So this is all about the other option. So consider to the answer for this question, which is the next best step in this patient. Imagine you are handling this patient in the casualty. Always go for IV dose of furosemide or an equivalent stepped up dose of torsemide also. So other option we have discussed why it is not correct. Just one extension of the same question. ठीक है, हमने तो दे दिया Lasix furosemide 40 mg IV. ठीक है, this patient received an infusion of 5 mg per hour and his urine output have increased, and over the next 2 days patient is symptomatically better. His AKI, hypertension all are improving, volume overload symptoms are also improving. Now you are planning to discharge this patient. So how you are going to convert this furosemide from IV to oral? This question all the postgraduate students who have posted under nephrology department, every discharge care, they have the doubt. Sir, patient is on IV furosemide 40 mg. What should be the equivalent dose? You will understand it better now as the discussion goes on. What are the options you are having to convert it? So what of the following option, which is the most appropriate diuretic regimen you will select? Furosemide 120 mg along with the metalazone, which is the sequential nephron blockade. You are blocking sodium potassium 2 chloride channel with the help of loop diuretic, and you are blocking the distal tubule with the help of the metallazone. Whether you will select this, you have furosemide 80 mg BD, you have furosemide 160 mg per day, bumetanide 4 mg twice daily will you select, or bumetanide 4 mg once daily will you select. So today you are going to discharge this patient. What you are going to write in the discharge card, which is correct. We'll see one by one. What to consider while switching the patient from IV loop diuretic to oral? You have to take into consideration the patient bioavailability, how much it is distributed, metabolism. This basic concept is required. Understanding of the drug is required. For example, if we take furosemide, furosemide is having the first pass metabolism. And because of this first pass metabolism, the oral bioavailability is somewhat lower for Lasix or furosemide than Ditar or torsemide and the bumetanide. I am omitting bumetanide from the discussion because in India the use of bumetanide is not that common. Our clinical day-to-day practice always revolves around these two drugs, where torsemide or Lasix, that question comes. Lasix is having a lesser bioavailability than Ditar. So this is having an implication while converting the drug from IV to oral. The furosemide dose should be doubled when making this change, whereas if you are giving Ditar as IV, the same dose to be continued. Is there any guideline which says? There is no guideline. There are some studies which states this. Since the bioavailability is more, oral and IV can be similar for torsemide or Ditar or Javitar, whatever the brand name you are using. For Lasix, you have to double it. But sure, is it compulsory in all the situation where I have to double the dose? No. The effective dose is determined by urine output and the patient response. We have to maintain an adequate urine output, or I can put it in another way. We have to make sure the patient is decongested and coming out of the volume overload. And also there is some theoretical point that loop diuretic dose response curve is sigmoidal and logarithmic. So exponential dose increase may be needed for patient who does not show the response. So that is why you have to see the patient response and the urine output, then decide on increasing the dose. Once the ceiling dose is achieved, the patient might not respond also. So that 2 point you have to take into consideration. Mostly the diuretic gets bind to the albumin and gets metabolized and eliminated by the liver or the kidney. Another point taken into consideration is the patient's serum albumin level. So if the patient's serum albumin is low, the dose which is required might be little bit on the higher side. You have to see why the patient albumin is low and take steps to improve the serum albumin. So let us come to the case 1 only. Since the patient after admission received a total of around 120 milligram, you take the initial bolus and the infusion that you have given. Take the total dose, which is approximately 120 milligram. With 120 milligram, the patient have achieved decongestion and he got symptomatically better. So I have to double it. The dose is 240 milligram per day. The patient have to take orally. If we go as per the theory, so instead of giving us 240 milligram per day, once daily dosing. If we want to give us twice daily, it is 120 milligram twice daily. Why we have to give as BD dose? To avoid the post diuretic sodium resorption. If you give it a high dose, there is a rebound sodium reabsorption occurs. So to avoid that, we give it as a BD dose. So in the case that we have discussed, 240 milligram will be 120 milligram will be converted into 240. Instead of giving as a single dose, I will give as 120 milligram twice daily. But Since the patient signs and symptoms of acute decompensated heart failure and AK is resolving, and since the patient is improving, we doesn't require a very high urine output. So we are considering a lower oral dose of furosemide, such as 80 milligram twice daily. Why I am taking 80 milligram? Because 120 milligram patient might go into hypovolemia. Since the target is achieved, I don't want further excessive urine output. I am reducing the dose. So that is how you have to decide on the urine output. What about the other option? Furosemide 120 milligram twice daily with metalazone. If we give, the patient might go into hypovolemia or some electrolyte abnormality can happen. Many a time because of the hypovolemia, patient might go into AK. So bumetanide, I don't want to discuss because it is not in common clinical practice. Usually prefer the drug as a BD dose rather than the OD dose. So the best option for the second part of the question is to prescribe furosemide 80 mg twice daily, because this 120 mg twice daily with metalazone will put the patient into hypovolemia or some kind of electrolyte abnormality. Furosemide 160 mg per day single dose probably cause rebound absorption of the sodium. Bumetanide we can omit from the option because we are not using it commonly. So the best option is 80 milligram twice daily for that particular patient. So have you seen how I calculate the dose of furosemide, and the patient response have to be monitored. Patient have to be maintained in the euvolemic state. So these are two simple case scenarios which help you to adjust the oral to IV and the IV back to oral. So next case I will upload soon. Okay, bye bye.